Okay, so definitely we have gone live onto YouTube, and Shilpa madam, we can now start it off.
Yeah, so today's topic is luteal phase support in natural and in IUI cycles. So this topic has been requested by many members, and I think this is something which has been discussed in multiple forums, multiple times, with multiple the time durations, but still there is so much of lack of clarity in this that we decided that yes, we need to do a short session on this, and I hope that it gives you some info, some clarity, and also some clinical points which you can utilize in your practice for the benefit of your patients. So yeah, over to you, Dr. Jai, to take it forward.
Okay, fine. So Shilpa madam, I would actually immediately wanting to start the whiteboard. So I will just let me know if the whiteboard is visible to you or not. Okay.
Yes, visible.
All right. So I think what is very important to understand for everybody is that what typically happens in a natural cycle. Okay. See, women who conceive naturally, totally naturally, okay, these people, they don't take any luteal phase support, no? So the luteal phase support to these women is actually provided by God in the form of something called as corpus luteum. Okay. So when I draw an ovary, Shilpa madam, I hope it is visible because I can't see any
Yes.
one of you. Okay.
Yes.
Yeah. Okay. So this corpus luteum, which is actually God gifted, all right, it develops from the dominant follicle. All right. And typically, what is important is something which we have discussed even in the previous lecture. Corpus luteum will secrete small amount of estrogen. It will secrete a good amount of progesterone, and both these people are going to go and act onto the endometrium, thereby inducing secretory changes over the endometrium. And these secretory changes which are induced over the endometrium are going to help in implantation. All right. So this is something which we understand. What typically happens is the oocyte which is released, let's assume it has formed a blastocyst embryo. And when there is implantation, so then through the invasion of the syncytial trophoblast, it is going to start releasing HCG. All this while, till HCG is getting released, see, post ovulation, okay, implantation is going to, let's say, occur on day 6 or day 7. And then HCG release typically happens by day 8 or day 9. Okay, this is our standard understanding. Till that time, it is our brain, especially the hypothalamo pituitary circuit, okay, so the HP axis, which allows for LH secretion. Okay, this LH secretion occurs in pulsatile manner, and this pulsatile manner of LH secretion allows to maintain the corpus luteum, which thereby allows to secrete estrogen in small quantities and progesterone in large quantities. Okay. After beta HCG comes inside the picture, what it does is beta HCG is a great molecule. The greatest thing with beta HCG is that beta HCG has something called as a longer life. It has a longer half-life. As a result of this, beta HCG starts going and acting onto the corpus luteum receptors, okay, in maintaining the corpus luteum. It allows to maintain the corpus luteum because both these people, both LH and beta HCG, the one thing which they share in common is the receptors. Okay, their receptors are almost alike and they share this in common, as a result of which HCG is used as a surrogate for LH across the entire practice of fertility. All right. Now, this is something which happens in a natural cycle. HCG will go and get bound to the corpus luteum for a very long period of time. As a result of HCG being bound for a long period of time, there is a prolonged secretion which occurs, HCG driven secretion of progesterone, HCG driven secretion of estrogen. All right. Now, all this is when you have something called as a normal corpus luteum. Okay. And this is something which occurs in a natural pregnancy. This is the same advantage you are trying to take of a normal corpus luteum when you are trying to do something called as a natural cycle transfer. Okay. In order to understand this, we will understand one very small concept. See, what typically happens in a menstrual cycle is first there is an FSH peak, then the FSH comes down. Then at the time of ovulation, there is a small FSH peak and it becomes fine. With LH, something different happens. LH is very small in the beginning, then it is at a plateau stage, and then there is a huge LH surge. With estrogen, what happens is estrogen starts growing here, then it starts growing here, then it comes again, and then there is a surge in estrogen, and then there is a plateau in the estrogen levels. Okay. The biggest problem which happens when you are doing something called as ovulation induction. Okay. When you are doing ovulation induction, the biggest problem happens is what we are all worried about, and that is something called as supra physiological levels of estrogen. Correct? This is something which we all agree to. Now, this supra physiological level of estrogen, which occurs through any form of stimulation, is going to be a negative response to this LH secretion. Now, because this supra physiological estradiol is negative to this LH secretion, it ultimately ends up destroying the pulsatile mechanism in which the LH is secreted, and it causes the corpus luteum in a stimulated cycle to be slightly defective. Now, because it is slightly defective, there is going to be a window where nobody can maintain the corpus luteum. There will be a drop in the progesterone, which will cause drop in the implantation, which will cause a loss of pregnancy, or which will cause a pregnancy to never happen. As a result of this entire understanding of physiology, we use something called as luteal phase support. Okay, this is the basis of anybody using luteal phase support. Okay, now I do understand that people mention that when you are using a letrozole induced cycle, okay, there is no need to use, any form of luteal phase support. That is good, but believe me, friends, put your hand on your heart and swear it in the name of your mother or daughter. Do you use letrozole and then don't give a luteal phase support? है ना? So that is practical purposes. All those things doesn't really happen. Everybody gives luteal phase support. So when we are looking at a luteal phase support, the important things which we have to understand from each other is this. What is the luteal phase support? Is there any role of luteal phase support in these three situations? Okay, so I'll make four situations actually to make life easy. First is our wonder drug, that is clomiphene. Second is letrozole. I will actually make it letrozole standard dose. Okay, standard dose of letrozole matlab you are giving 2.5 or 5 mg of letrozole, okay, for 5 days. This is your standard dose. Huh? Along with that, I will add gonadotropins. So any form of gonadotropins and any form of low dose HCG stimulation. Simultaneously, along with low dose HCG stimulation, I will also add extended letrozole. Okay. So these are our four typical stimulations which people will use as far as ovulation induction is concerned, or as far as IUI cycles are concerned. Okay. Fine. Very, very simple situation. In clomiphene, do you need to use luteal phase support or no? Answer is yes. Evidence for letrozole standard dose, the evidence is actually saying no, that no, it is not required, it doesn't really change, but the evidence says that if you use luteal phase support, there is no negative effect. Okay, that means if you use luteal phase support, it doesn't mean that the pregnancy won't happen. Correct? Then comes number 3, gonadotropin. 1000% yes. Why? Because in gonadotropin induced cycles, there is a good amount of supraphysiological level of estradiol, and this supraphysiological level of estradiol is going to 100% affect the LH pulsatile secretion. Okay. In low dose HCG protocol, extended letrozole protocol, it's 100% yes. Okay. Now, mind you, I am talking of all this despite giving a trigger of 10,000 HCG. All these guys know across the board will get a trigger of 10,000 HCG. So what will people think? Arey, 10,000 HCG trigger is itself enough. 10,000 HCG trigger is itself enough to maintain the luteal phase. Why do you need to add it? The answer is, despite giving a 10,000 HCG trigger in any of these situations, the standard practice is to add it, because There are very few people who, unless they are hardcore that nahi, I will wait for ovulation to occur, then I will time it and then I will calculate it for the sake of practical purposes. Almost what everyone does on earth is that they are going to give a trigger of 10,000 HCG. Despite giving trigger of 10,000 HCG, the evidence remains the same. Clomiphene, yes. Letrozole, yes. No negative effect of using gonadotropin 1000%, low dose HCG 100%. If you give any other trigger in your ovulation induction or IUI cycles, we've already told you it is going to be detrimental in all that situations. If you give any other trigger, you will have to use luteal phase support plus add back HCG, and of course it is going to reduce your pregnancy rates for sure, because the defect in the corpus luteum, which is then induced by a GnRH agonist. Okay, remember one thing, a GnRH agonist is actually luteolytic. So the defect in corpus luteum by a GnRH agonist is massive, and it actually causes something called as not just corpus luteum defect, it causes defective corpus luteum plus luteolysis. And as a result of which, usage of luteal phase support in all that is considered to be absolutely standard. All right. So with this much being sort of discussed on a single slide, I hope everybody has understood the basic mechanism as to why we need to use luteal phase support for ovulation induction cycles. And simultaneously, I hope people have understood that irrespective of what anyone says, especially with letrozole, when people are trying to tell you that when you're using 5 days of letrozole, you don't need luteal phase support, people still use luteal phase support. Okay, so there is no evidence which says that if you use luteal phase support with letrozole, you are making a criminal offense. No such thing. Okay, you may choose to not use it. Now listen, in countries abroad, okay, there is a big problem as far as luteal phase support is concerned, because they do not have anything called as loan license arrangement for production of progesterone. Everybody has to produce progesterone by sourcing the raw material. So production of progesterone is expensive. Okay, in India or in let's say one level below developing countries, let's just put it that way. In developing countries, what typically happens is that there is one factory in the country which manufactures progesterone, and this manufacturing company allows you to co-brand it. Okay, and you can distribute in as many brands in India and you can distribute it as many brands abroad. Okay, now that is something called as a loan license arrangement, which happens in India, which is why the cost of raw material goes down, as they can use slightly cheaper raw materials and they can have a huge production capacity, which ultimately reduces the cost, which is not true for other countries. Okay, which is why we should never get carried away when somebody from Denmark comes to us and tells us that no, they don't use luteal phase support in letrozole. Very good, don't use it. But in India, you should continue to use it, in my opinion. Okay. Okay, so the next question which people will ask all of us is that I do understand all these things, all right, but what is the luteal phase support that you are going to recommend in any of these cycles? Okay, so remember one thing, the best luteal phase support you can give, okay, to any patient is going to be progesterone. Okay, this progesterone, when you give, the best way to administer the progesterone, actually, irrespective of what anyone says, is in the form of the vaginal route. We all know oral route has a high first pass metabolism. We all know aqueous injections as well as oil-based injections can be painful. And we all know that when we give it vaginally in the form of either capsules or in the form of gel, that is something which is convenient for the patient to take, and it is very effective. Okay. There are some people who will say, what is the use of Dufaston in this? So remember, you can easily use Dufaston. It is no problem in using Dufaston. It's a great drug. The dose of Dufaston for luteal phase support in IVF, as far as IVF is concerned, is 3 tablets. Okay, 111. The dose as far as IUI cycles is concerned can be 101. If in case you are a hardcore fan of using just luteal phase support. All right. Simultaneously, vaginal progesterone gel, if you are using progesterone gel and if the weight of the patient is less than 50 kgs, then a single application in the night is enough. If the weight of the patient is more than 50 kgs, 2 applications are better to give to the patient. This is what we have standardized. Of course, there is no guidelines to this. There are many people abroad who use a single application of gel for even 125 kg patients. That is completely their choice. For Indian patients, this is what we have standardized. We get very good results with this. We don't plan to change it. Okay. As far as vaginal micronized progesterone capsules are concerned, there is a sustained release vaginal 400 microgram progesterone capsule, which is available. If you want to use, you can use 2 capsules in a day, 1 in the morning, 1 in the evening. Okay. Before you use any luteal phase in the support in the vagina, just keep one very small thing in your mind, that it's preferable that there is no active bacterial vaginosis. Okay, the vagina should be free of any active bacterial vaginosis. Of course, all of us are in a habit, or our assistants are in a habit of examining the vagina through a cuspospeculum. When the patient has come for IUI, or when the patient has planned relations and all these things, all of us do examine that. And one thing which we add to all these patients compulsorily is we add a probiotic. Okay, so the probiotic which we normally add is an oral probiotic. Oral probiotic is much more effective than a vaginal probiotic, because the concentration through an oral probiotic has been proven without doubt that it is much higher as compared to a vaginal probiotic. All right. Following this, okay, this is your thing for a standard cycle for IUI, irrespective of your stimulation. This is your thing for a standard cycle of timed intercourse, ovulation, induction, irrespective of anything else. But just remember one thing, the final thing which I want to address is when people ask when to start it. Okay, when to start the luteal phase support. See, once you give an injection of HCG 10,000, okay, the simplest thing which we tell is, let's say you have given HCG 10,000 on Monday, you start the luteal phase support on Wednesday. Let's say you have given it on Tuesday, you start it on Thursday. Do not go by calculation of timing based on 36, 42, 48 hours and all these things. All right. If the patient has come to you Monday evening, 6 o'clock, you have given them an HCG trigger at Monday evening, 6 o'clock, Wednesday morning, by around 8 o'clock-ish, 9 o'clock-ish, patient should start luteal phase support. Simple. If the patient has come on Monday morning, 10 o'clock, still Wednesday morning, 8 o'clock, 9 o'clock, 10 o'clock, patient can start luteal phase support. Okay, that much window HCG will offer, and that much window HCG will give you without distorting the endometrial synchrony. So don't worry about that. Okay, but keep in mind that the minute you start altering the rhythm, otherwise, when you are using complete pure natural cycle embryo transfer, we don't give luteal phase support. Okay, when we allow the follicle to rupture on its own, when we document the rupture and we do an embryo transfer, okay, as a part of FET cycles, for a pure natural cycle, we don't give luteal phase support in that. But the minute we modify it, okay, so what is a modified cycle? You are following it up, follicle is 19 millimeters, good vascularity, and you've given an HCG 10,000 trigger. In that situation, on the day 2, you are going to give luteal phase support. There is no doubt about it. Okay, there is no doubt in that. The minute you fiddle around with anything in the natural cycle, you will require luteal phase support, because no matter who you are and how great you are, okay, nobody can predict the LH pulsatile frequency and the changes which that LH pulsatile frequency will undergo due to the dose of estradiol, okay, or due to the development of estradiol through that follicle in a particular lady. You can't really individualize it. There is no such individualization or testing which is available. And as a result of which, it is really important to keep one protocol in your head, irrespective of the stimulation which you use. I'm repeating, even if you are scared that if you use letrozole, you can't use luteal phase support, you are wrong. The study has said that it is not needed, but the study has not said that when you give luteal phase support, patient will die. There is no such thing. Understanding? You give luteal phase support, pregnancy outcomes are the same. Okay, there is no such thing. It is just that if you give or if you don't give, it doesn't change the pregnancy outcomes. So in order to run a happy practice in practical aspect, it is better to give at all stimulations, all age groups, as far as it is ovulation induction or it is IUI. Okay, so I hope this 20 minutes which I spoke covers almost every practical aspect of the topic. And I can't really compress it and make it as more simpler than this by explaining the physiology and everything together. And if there are any doubts or questions, we can have 3 questions which are asked here, and rest of the questions we'll ask on WhatsApp.
No, it was very, very good. So one thing is, do you continue it once the UPT comes positive?
Yeah. So, okay, that's a good thing. I have a very simple protocol. The luteal placental shift will occur between 9 to 10 weeks. Sometimes people are saying 8 to 9 weeks, but practical purposes, we take it as the third visit of pregnancy. So that is around 10 to 11 weeks. Okay. Once the patient comes at 10 to 11 weeks, and if the NT scan is normal, okay, if the NT scan is normal, we ask the patient to stop the progesterone gel. We normally give only progesterone gel to the patients. We do not give Dufaston to our patients for IUI cycles or ovulation induction cycles with timed intercourse. The only thing we give is progesterone gel. The minute the patient comes and NT scan is documented normal, progesterone gel stops.
Okay. And have you noticed increased in ectopic pregnancy incidence if you started like 48 hours later? Should we delay it further, or it's just like theory where
The
they say?
See, the biggest problem about ectopic and trying to worry about ectopic is, even if you don't give luteal phase support, let's assume you don't give luteal phase support, in your practical life, how many ectopics have you seen in patients who have conceived naturally and there is an ectopic, compared to patient who has conceived with IUI and there is an ectopic? The ratio of people who have conceived naturally with ectopic is way higher, because if you want to blame it on ectopic, it is the tubal factor and not the luteal phase support. This dose of progesterone has got nothing to do with the ciliary motility which occurs in the fallopian tube to distort the motility. Understanding, it has got nothing to do with that. The reason being, the amount of receptors which are present inside the fallopian tube through the cilia are maybe 1,000th or 1 lakh less than what it is present in the endometrium. So one should not get worried about it.
Okay. And last thing is, do you give HCG for luteal phase support in any situations, or do you think, I mean, it's worthwhile exploring?
See, honestly, the HCG which is secreted by the embryo or by the syncytial trophoblast, let's put it that way, okay, is way higher. Okay, way higher. What is the dose? I mean, how much is the HCG that is present at 6 weeks of pregnancy, right? If you ever do a beta HCG test, look at the value it comes: 18,685, 25,800. Correct. Now that is 25,800 at that time in the blood. So the amount of HCG which is secreted by the syncytial trophoblast is way more than what you can administer. So if you want to give additional dosages, let's say 5,000 HCG or let's say 10,000 HCG, understanding, it is like you are having a glass full of water and you are adding 1 drop of HCG on it. So that 1 drop of HCG has got no meaning, in my opinion. It doesn't really help as far as these cycles are concerned. There are some people who would use HCG add back. Okay, where they want to use that small HCG 2,500 units, 2,000 units. But I am not a big fan of it because it severely distorts the endometrial receptivity. So I don't use it in practice. But yes, there are people who would like to use it or at least speak about it even if they don't use it.
Okay, compared to vaginal progesterone capsules and gel, I mean, why have you shifted over to gel?
No, it's just because gel is it's very convenient. See, it is very tough for someone to put that vaginal capsule without an applicator right in the posterior fornix. The advantage with the gel is that what happens is in fact, the best time to put the gel, I think, is in the morning. Because
Yes.
what happens is, once the lady puts the gel and she goes to work, or she's doing whatever activity, when they walk, the anterior posterior wall of the vagina would rub against each other, and it will cause slightly better absorption of that gel. Okay, and
Yes.
plus gel has a long shaft. So whatever dose you are injecting, it goes in the upper 1/3 of the vagina, where absorption and action close to the cervix is much better, is what I think.
Yes. I think that was a good one. So universally, all stimulated cycles, all IUI cycles, progesterone is the way forward, either vaginal pessaries or it could be the vaginal gels. And there is, do you measure progesterone levels in any of the cases?
No, we don't. But we do measure it in IVF prior to, if they are HRT cycles, then we measure it prior to starting the progesterone. If it is less than 1.5, then we start progesterone.
Okay. Yeah. So do you measure LH levels when you like do the IUI or like to check whether?
So because we have a very, we have an in-house system to measure all these things. So yes, we do measure LH levels prior to doing ovulation induction as well as prior to doing IUI. And that is predominantly for us to decide if a trigger is needed or not. See, when LH value at any particular point in time exceeds, let's say 17, 18, no? That means the LH has surged, irrespective of the pulsatile aspect. Let's assume the pulse has died out and still you have measured the serum LH. Okay. And if the LH value, resting value of the LH is more than 15, 20, that means the patient has surged. You don't really have to trigger that patient. Understanding the secretory changes have already started to occur. The early corpus luteum has already started to form, and the granulasa cells have already started the process of undergoing luteinization. So you don't have to then give an HCG 10,000. But if the LH value is less than 10, less than 12, all these things, then definitely better to give an HCG trigger and do IUI on the, the day after.
Okay, so we have a few questions. One is this one we take. Repeat the dosage of progesterone capsules recommended.
400 BD.
Any role of injectable progesterone along with oral or vaginal route?
I don't give at least.
Yeah, I think that's about it. So do you use progesterone injection like aqueous injection or even the injections?
No, not in IUIs and not in ovulation inductions.
Okay, but yeah, the IVF part we'll discuss later. Okay, yeah, then yeah, I think that's about it. We have covered. So anything else you would like? What about the sustained release progesterone oral capsules? Do you have?
I don't use them at all.
And the vaginal, the VT, the dispersible ones?
They are good. They are very good. There is no problem. I never use a combination of two progesterones in IUI and OINI. That means I don't use dufaston plus progesterone. I don't do that in IUI cycles or in ovulation induction. There is no role. Okay, so there is no role. And one of the reasons why I don't do that is because all these things are a part of my package. I don't ask the patient to go and buy it from the pharmacy to add to the pharmacy income. Understanding? It's a part of my package. So I have, streamlined the package in a manner where the input cost is the least, the output is the maximum. Okay.
Yeah.
But I don't use two progesterones. Single progesterone is more than enough. In IVF, yes. In IVF, I use two, dufaston and vaginal gel. I have shared my prescriptions many times. But in IUI cycles, I just use progesterone gel. I have shared that also many times actually. But I just use progesterone gel. I don't use dufaston in that.
So this progesterone gel, does it need to be refrigerated?
Less than 25 degrees.
Okay. Yeah. Yeah, I think that's about it. We'll answer the rest in the
on WhatsApp.
Yeah.
Okay.
Thank you so
Shilpa,
much.
madam. Thank you.
Very, I think very
to
good.
all the people, actually, you must just bug Shilpa madam about this because it is her initiative. She has taken the pain and efforts of all these things. So any more suggestions for taking sessions and questions and everything should be addressed to her. And I honestly never imagined that it would be such a big success. So thank you so much, guys.